So, Professor Watson, what was your first ESPN memory?
I think the first ESPN memory I have is actually the combined meeting of the ESPN and the IPNA in 1983 in Hanover. I was working as a fellow in Toronto at the time and came across to the meeting, and I was really excited. It was an absolutely lovely weather. I remember strolling around in Hanover and meeting all these people who had sort of developed or started up paediatric nephrology. This Brodell, who was organising the meeting, Carl Shearer, Rennie Habib, Stuart Cameron, all these names that have been quoted as the original founding members, and just feeling the kind of excitement and the interest that was generated in the discussions from the presentations.
And what, from the kind of medical side of things, what were the main subjects or the kind of keynotes, kind of topics that you can remember from that meeting?
Well, I think the meetings have always been a little bit two-sided in a way, because there are a large number, of course, of paediatricians with an interest in paediatric nephrology in that they don't do end-stage renal failure work. And so I always remember that UTI was and remains a controversial topic. I think the histological studies that were coming to forth through the work of Habib and others about the classifications of the histology of the kidneys. And of course, we didn't really have and we still don't have the magic bullets to treat many of these conditions. So again, the discussions on nephrotic syndromes were coming through. The Germans were doing studies on various steroid regimes even then.
And from a social point of view, what do you remember from that meeting?
I remember the wonderful atmosphere. I think quite a few of the attendants were from the original ESPN founders members meeting, and so I think they were accustomed to bringing their wives and partners, and so there was a very kind of relaxed social, and it was a great opportunity to enjoy another European city.
And during your career, what would you say was the biggest medical treatment advance that you saw?
Well, I think in a way, on reflection, it probably has to be the success of renal transplantation. After all, we are dealing with children with a chronic illness which affects their growth and development and their whole stature, and that can only really be transformed by kidney transplantation. And of course, up until the early 80s, we only really had azathioprine and prednisolone, and some children did very well from that, but a lot of children had rejection. And I think the use of cyclosporin and tacrolimus and those combination of drugs has now given us the opportunity to transplant children at younger and younger ages, and actually to see that they can grow and prosper and develop and have a really, really normal childhood. I think the kind of concept that chronic kidney disease was then treated with dialysis, which was then treated with transplantation, can now really be shortcut by going straight from chronic kidney disease to transplantation at the appropriate time.
And what do you see with transplantation going forward? What would you kind of predict or see on the horizon of changes that might come about?
Well, I think we've struggled, obviously, still to get other species as suitable donors, thinking of the pig story, etc. But we have actually taken big steps to try to actually expand the pool of donors by using living related donors, non-living non-related donors, and looking to prioritize children, I think, Children are fortunately in many countries are a priority for kidney transplantation, but I think it's such a profound effect upon them that I think we have to redouble our efforts in order to make them a priority and to avoid sensitizing episodes and possibly try to avoid dialysis access because they're undoubtedly going to need future transplants when they are adults. And I think that the more we can preserve dialysis sites, the better, but at the same time pushing for earlier transplantation.
So I just wanted to ask what conditions were like in the hospital where you worked and in the kind of unit that you worked or maybe had to set up at the start of your nephrology career.
Well, I was very fortunate in a way in that I'd had training originally in Manchester with Ian Houston and Bob Postlethwaite, and then I had trained in the Toronto Hospital for Children, where I was a fellow and then on staff for 2 years. So I had the experience in Britain and in Canada to meld together. So the opportunity came to create a unit here in Nottingham to serve the East Midlands or the Trent region of England, where there wasn't a service. Previously children either died or were sent sometimes south or were sometimes treated by the adults if they were big enough. So I was able to set up a unit from scratch, and it had to be a unit that delivered all aspects of renal care, including the management of acute and chronic kidney failure. What was interesting was that I had numerous battles to fight, and I think perhaps people these days don't appreciate how hard it was to establish units at that time. Originally the units in the UK had super-regional funding, but that was lost when we created additional units, and so you had to work with the administration or try to convince the administration of the need for it. And very early on I said, well, when I set out my stall, if you like, I said not only do we need the liaison with the specialist nurses and surgeons, of course, but we needed to have the dietetic input. We needed to have the psychosocial dimension with the appointment of play leaders, so psychologists and social workers. And so I was fortunate in that respect, in that I was able to create very quickly a multidisciplinary team, and psychosocial aspects of chronic renal failure have been one of my particular interests. It hasn't been easy, and of course I didn't expect that I would be working one-in-one for 7.5 years. That might be quite a shock to many junior doctors these days, but in fact when my colleague Jonathan Evans joined me, we were only 1-in-2 for 7.5 years. So that was incredibly demanding, certainly demanding on family time, but nevertheless I think I only accomplished it because I had the support of a multidisciplinary team that were able to carry out quite a lot of the workload. As well, I tried to orchestrate what was necessary behind the scenes.
You mentioned there about the psychosocial aspect being an interest of yours. What have been your kind of research interests or areas of paediatric nephrology that have piqued your interest the most, would you say, during your career?
Well, I was when I arrived again in Nottingham, one of the first patients I was asked to see were parents whose child had been diagnosed in the womb as having a major renal problem. Subsequently that child was born and there was absolutely no abnormality to be found. So very quickly I recognized, well, what is going on here? And so I got into the antenatal counselling for renal problems and neurological problems very early on, and I've been keeping registries of the outcomes for some of those patients, and we've written about them and spoken about them, and it's been a fascinating development because in a way there is so much uncertainty, and you have to communicate very skillfully, I think, with the parents based on your own knowledge, because what you're dealing with is the uncertainty of many of these conditions, the uncertain outcome for many of these conditions, particularly if the kidneys are severely affected. And I think I've always promoted in our region that the nephrology staff are very much involved from the outset, as well as discussing things with the urological colleagues as you go along. I've been particularly interested in aspects of dialysis, particularly my interest in vascular access, where we developed our own jugular venous catheter when I was in Toronto, and advocating, if you like, no needle, pain-free hemodialysis, which can be achieved, of course, through these necklines, which, if properly looked after, can last for some considerable period of time. Particularly interested in aspects of peritoneal dialysis and the evolution that we've gone through from CAPD to CCPD or automated PD, and the ability to manage children at home in their community. But of course, along with that came the recognition that we were putting tremendous stress on the parents, and the psychosocial support became even more paramount. And so that's something I have written about, and rather regret that we haven't done more, knowing that this is a partnership with our patients and their families, but sometimes they're doing all the work at home and need our support very much so. I mean, I've been fortunate that I've been able to participate in European multi-center studies, particularly with transplant drugs. I think that's been a very worthwhile undertaking, and the various international studies that we've collaborated with have also been very fulfilling.
I understand that you're involved in the European working group for dialysis. I was wondering if you could tell us a bit about that and the collaborative work you did.
Yes, I think this was an exciting venture, because in 1999 there were about 12 paediatric nephrologists from about 12 European countries came together under the umbrella of the European Paediatric Peritoneal Dialysis Working Group in order to look at the development of guidelines and protocols for the management of children on peritoneal dialysis, but also came to expand that to the management of children on dialysis and actually even pre-dialysis. So this was, we produced our first guideline on the management of children on chronic peritoneal dialysis in early 2002, and we subsequently produced several guidelines covering anemia, bone mineral metabolism, peritonitis, at the same time as others were developing international peritonitis, pediatric peritoneal registries. It was actually a fascinating exercise, because not many of the subjects or the protocols have been tested in formal trials in pediatrics because of numbers. So a lot of it was opinion based. However, having people from 12 different countries represented in the group, it brought together a fascinating wealth of opinion, and after careful debate we had to settle on certain items to go into the protocols. I'm glad to see that the group is still in existence, and that the European Society of Paediatric Nephrology has actually taken on the brief of actually forming various working groups in other areas such as transplantation, in order that they can actually encompass the best guidance for these children. I think this is still necessary, and it's surprising that it's taken that long. So I hope in the next decade or so ESPN will have developed guidance and help to promote the safe management of children with chronic kidney disease.
I understand you've been involved in medical ethics at your institution. I was wondering if you could tell us a bit more about that.
Well, what I often say now to other doctors is the problems in medicine aren't medical, they're ethical and sometimes political. And of course we appreciate that although we might be able to provide all manner of services in terms of dialysis techniques, for instance, to any child at any time with acute or chronic kidney disease, that isn't the case around the world, where even today many children are dying because of the lack of acute dialysis facilities, even if they have simple post-strep glomerulonephritis, which they could recover from quite completely. And chronic kidney disease doesn't feature in many countries because of the cost of resources. But in a way, we have become victims of our own success in if you like, westernized society, in that we're faced with dilemmas of long-term dialysis for children who have major other comorbidities, which we wouldn't have 20 or 30 years ago, where I think it was the picture was much clearer and it was harder to advance a case. But now, of course, we have to be much more circumspect and deal with the desires and the expectations of parents and families, because they expect us to cure their conditions, their child's condition, and of course many conditions are not curable, you know, they're only kind of treatable and ameliorated. So I think this has resulted in dilemmas, particularly in infants, where and highlighted again by some of the antenatal problems that have been thrown up, is to how we cope with severely handicapped children, handicapped from the point of view of comorbidities with their chest, brain abnormalities, as well as kidney failure. So in 1999, I spoke to the medical director of the hospital about the fact that we had these ethical dilemmas, and he said, well, why don't you establish a committee? And that's what we did, and we had the longest running ethics of clinical practice committee for all of medicine, not just for paediatric nephrology problems in the UK. And I subsequently went on to be the founder chairman of the UK Clinical Ethics Network. So I've always actually been keen that ethical issues, although they may have no quick fix to them, should be discussed and debated. And I think this is a skill and a necessity, if you like, that many junior doctors need to grapple with, because they are the ones that will have to be the decision makers, or to be those who are trying to reach a consensus decision when these problems arise.
So looking back on your career, if you could change one thing in terms of management or care for patients, what would be the thing that you would most like to change?
Well, I wouldn't have changed very much, because it has been an actually great privilege to look after these children and their families and to work with a multi-professional team. I would have thought that obviously the kind of amount of demands upon my own time was really quite exceptional, and I would have liked more colleague support at an earlier stage, obviously, because I do believe that sharing that expertise reduces the likelihood of stress and burnout, which I think is a phenomenon in the long term when you're dealing with such a stressful subject as paediatric nephrology. But I also feel with more time I might have been able to be more productive in terms of research and production of good quality materials I was very interested in producing information materials, for instance, for children and their parents, and these can be as demanding as writing an actual paper. We did get them done, but it required quite a lot of effort. I think, in a way, what I always tell junior staff is that obviously there are many aspects to clinical care, and I think as well as the actual clinical attention, I think that one has to deal with management issues, because it's important that we do justify what we do, and I think it's important to participate in research. Some of the best fun I have had is really attending research meetings throughout some wonderful places in Europe, and as a result of researching and talking at meetings, you get sometimes more invitations, and I've enjoyed many international meetings with colleagues in the States, and also through the working with the IPNA Council. So I think the more you put in, the more you can get out sometimes, and I would encourage junior doctors to consider their academic portfolios, as they would now be described, and actually participate more, because there is so much to information to swap, there is so much information to spread around, and there's so much more to be discerned so that we can optimize the management of our children and families with chronic kidney disease.
I understand you're involved in setting up a sister renal unit abroad. Can you tell us a bit about that?
Yes, this was again a very worthwhile venture. It was the formation of a sister unit whereby a kind of, if you like, a modern westernized unit took on responsibility for the development, assisted the development of one in a developing country, was one that was promulgated by the International Society of Nephrology, and also adopted partly by the IPNA Council as well. We had two Sudanese doctors who trained as paediatric nephrologists and spent part of their training in Sheffield with attachments here in Nottingham, and they were supported to develop a paediatric renal unit in Soba University Hospital in Khartoum in Sudan. So that actually involved visits from myself and also the head nurse and dietitian on more than one occasion, and they also paid repeat visits here. And through that support, we were able to help them to make a case to the management for the development of a transplant unit that was attracted private funding from the Gulf, that they had already developed chronic peritoneal dialysis support, that they already had a well-established and expanding hemodialysis unit. So within the space of about 5 years, they were able to offer all the facilities of a comprehensive paediatric nephrology service. And in fact, they themselves could then become a training unit for other units from other parts of Africa adjacent to them. So although there had been comprehensive facilities in South Africa, in Southern Africa, there was very little in Sub-Saharan Africa, and it was great to see the development of this sister renal unit. Again, I think there is mutual benefit from the sister renal unit and the senior unit, and I think it's been a very worthwhile venture.
So if you could give advice to the next generation of paediatric nephrologists, what would be your top tips for the future?
I think if I was giving advice, I would say that paediatric nephrology is a tremendous subject. I mean, it not only embraces the clinical aspects of acute medical management, chronic medical management, but also embraces so many subspecialties in terms of immunology, in terms of hematology, in terms of bone mineral metabolism, as well as the psychosocial aspects of management for these patients and their families. I think there are great opportunities to participate in collaborative research. We need collaborative research because the patient numbers are generally quite small between units. I think it's good fun to participate in collaborative research, as well as to stand up and discuss your findings from your own research and research going on in your unit. It's hard work and very stressful, and therefore you not only need good colleagues, you need the support of a multi-professional team. I've often said that it's not how you greet your successes, it's how you deal with your failures, because there will be failures along the way, and I think that it's important that people realize that we can only do our best, but what is the best is actually still debatable, and is something that I think we need to keep focused on all the time. There are still not many true guidelines that are actually that prescriptive for how we should be managing some of these problems. Amongst all that, I think one should attempt to have fun. One should attempt to smile and be bright and be positive, and I think that the patients and the families discern that very quickly in people who are helping them. So I think at the end of the day, there's lots to be done, there's lots to be learnt, and there's lots to be developed. Best of luck.